Hi everyone, I'm Dr. Dan Ratner, and this is Crushing Doubt. I'm here with Julie Conrad, as always. How are you, Julie?
I'm great. How are you?
I am doing very well. So, I had a particular topic I wanted to talk about. In this first segment of every show, we like to talk about doubt in some form.
Mm-hmm.
It could be a pop culture thing, it could be some aspect of doubt, and really, it's kind of at my discretion, I have to admit. And sometimes I doubt what I should talk about, so there you go. But what I would like to talk about today, I think about this a lot, especially with kids, is I kind of want to think about, well, I was going to talk about altruism, but I think that actually bullying fits in here too, because in a way that's the opposite of altruism, because bullying is tearing someone down. And one of the things that I want to promote on this show is building each other up. But I wanted to talk about it from a doubt standpoint. And part of what I'm thinking about is that one of the reasons that altruism is so good is that it builds somebody up. It gives something to someone. And a lot of times we actually almost tease people for being nice. Now, of course, you and I are from Cleveland, so that doesn't happen here. No. But
wait, can I ask you something about altruism really quick?
Yes, please do.
Okay. So how much is the idea of altruism about doing something for someone because it makes you feel good?
Right. You're asking what I call the Ayn Rand question. It's because I've had people argue that you can't do anything for actual generosity's sake, and I definitely do not agree with that at all. I do think you get something out of it. There's something that can feel good about giving to people, but I do not believe that giving to people is just secretly a selfish gesture wrapped in a beautiful package.
Right.
I actually think that, because one of the things that I think about is, first of all, altruism is just good. If you do something for somebody else that builds them up, they go on their way and they come to some other situation and they're better off for it.
Right. And they'll probably pass it on as well.
They will, and not only that, they'll have the freedom to, or the bandwidth to be there for someone else. Now, when it comes to symptoms, and this is something I want to talk about on this show all the time, is symptoms, of course, but people who are suffering from these symptoms, they're already hurting. They're already hurting a lot. If you're not being altruistic or generous, and I'm not trying to, be Pollyannish and say you've always got to be nice or anything like that, but you better be. No, I'm kidding. I actually do think, though, that you're doing more good than you know when you're passing on these good feelings. And one of the things that you're doing is you're passing on a good feeling in the body.
Absolutely, yes.
Think about what it's like when somebody insults you. What happens to your body? It's just like the whole body goes, and I don't care how sensitive or not you are, your body responds to that as if you've been attacked, because you have been.
Right, absolutely.
So I think we want to be more protective of each other. And again, there are some people who will try to tease about this kind of thing, and this is one thing I do on the show. I want you to not have doubt about who you are.
How does that happen? Like when they're...
Oh, I'll give you a good example. So, this is a very nerdy example, and it relates to my fantasy sports show, actually. So, I am the commissioner of a fantasy sports baseball league, and I really work very hard to get people to see eye to eye, to get along, to have it run smooth. And at one point, somebody was complimenting me for this, and I was eating it up. It feels good. I worked hard for that. And then another person complimented me. And then somebody said, enough of the positivity about it. It's like, especially with men, there's something about the toxic masculinity piece of it where, I don't know, does this happen with women? I don't know. Do you ever get teased for being nice?
No. I get complimented for being nice.
Women are great.
It's definitely not in a teasing way at all. I mean, it would be one thing if, I was just outwardly owning all of that. That would be kind of obnoxious, probably. If I was like, yeah, I'm great. Yeah, I'm just going to keep showering.
Tell me more.
But I think that there's really something beautiful about, especially with women, we encourage each other, and I'm sure men do too, but there isn't a teasing nature about it. It's just like, oh, it feels so good to drop off a meal for someone because they just had a baby, or, picking up a coffee for someone that's having a bad day, or, that kind of a thing. I think it's done a lot more openly than maybe, I mean, I don't know that, that happens a lot, just with men bringing somebody a coffee. Unless it's, someone there.
God, we're terrible.
I know.
But, but this is part of why I want to talk
about
this.
That's a stereotype too, because, I would think, oh, if someone's bringing you something, do they want something, especially if it's someone you don't know very well. But
good point.
I don't really think that's what you're talking about.
Well, but it kind of is to the heart of the matter, because what I want is to build trust about altruism. Mm-hmm. I don't want there to be this doubt about altruism. There's like, people are like, what? Why were you being nice to me?
Well, don't you think that's different too in different parts of the world? Because you lived in New York, you lived in LA too, right? Like two areas that people associate, maybe that it's not, it's kind of, all for one for all kind of mentality. And I know not all people are like that, but,
Well, in New York, it was more all for one.
All for one. Right.
There was no all.
But people will always say, coming to the Midwest, that there's such a feeling of generosity and openness and people doing things. Someone moves in the neighborhood and you bring them a meal, or, you make sure to make a point to get to know them. I don't know how that feels coming from, I mean, I know you're from here, but being away for so long, did it feel refreshing to come back? And did you have doubt about that? Like, oh,
Oh, no, I loved it. It was one of the reasons I wanted to come back for it, because I remembered it well, and I needed it. Mm-hmm. But I will tell you, one of the reasons that I needed it is that, in a weird way, when you're in an environment like New York, and I love New York in a lot of ways, but there's all kinds of great things about it, but this was not one of them for me. Mm-hmm. Some people love it. Actually, when I was moving away, there was a guy I knew who was like, I don't want to go to a place where they ask you how your sandwich is. He was like, I don't want that. And I was like, what? I want people to ask me how my sandwich is all the time. So I guess there's differences.
It's okay.
It just,
some people just don't want that.
This kind of is the point of what I was getting at, is that to have the wherewithal and the comfort to be who you are, that is a non-doubting sort of place. And I do think that altruism, maybe it's not for everybody. Maybe that guy who doesn't even want you to ask about his sandwich, he's not going to want to do altruism. That's a funny way to phrase it. Do altruism. What does that even mean? But I think, the idea of bringing good things to people, some people really thrive on that and need that. Mm-hmm. And I think the idea of helping people not doubt themselves and to build them up gives them the opportunity to be themselves, to feel better in their bodies. So this was an interesting topic for me that wouldn't necessarily seem like it relates to doubt, but I really think it does.
Well, what about also if you are someone who does a lot for others, do you find that these people are also the least likely to be able to receive back? Because I find that they can give, but it's really also, that it's difficult to receive because we're not really taught how to receive that goodness and that generosity. At one time, I think that was part of your upbringing, but that doesn't seem to always be the case now. And I feel that especially when people are in desperate need, say they are incapacitated by their pain, or they just gave birth, or they're in a family crisis, receiving that love and that support would feed the body, would bring
That's
healing.
a very good point. Yeah, I mean, I had to learn that more from a point of vulnerability. From a kind of trauma standpoint, it was easier for me to give than it was to actually let somebody help me. I wasn't, like controlling of them helping me, but it would just be like, hey, I'd let them help me. But I'm talking in a deep emotional way where I'd go to somebody and say, yeah, go ahead.
Oh, I had a friend recently tell me, we just became pretty good friends this year, and she did something nice for me, I did something nice back for her, and she's like, we don't have to be that way. That's not this kind of friendship is, I give to you and you give back and there's a scorekeeping going on. Like, don't feel like you have to do that. And I really wasn't completely feeling that way, but she did pick up on it, and that was so freeing to me because who wants to keep count? If you want to be nice, be nice. Receive it when it's given to you.
Yeah, actually, I'm glad you're making that point, because I don't want to come across as if I'm assigning altruism, because I'm not. And in fact, what you're saying is you have to be, I mean, I don't know if you can be altruistic to yourself. I have to look that up in the dictionary and see if that word actually would apply. But I think people know what I mean when I say that. You do have to give to you. There are times where giving to other people feels good. There's times where keeping something for yourself, maybe hopefully not in a clearly demarcated, selfish way, but
that's a big
can
thing.
Feel good.
Keeping things for yourself, because I'm kind of a give it all away type of person, and that's been a huge thing that I've had to learn is not giving it all away.
Yeah, and to me, all of it does relate to doubt. I'm sorry to hammer away on that topic, but it is kind of our theme. I think it's so important to feel comfortable in yourself, whether it's I'm going to keep this for me or I don't want to do this. The ability to say no is not, sometimes that's actually also giving to the other person. It's just like, you know what, let's not do this thing where you're not clear on where I stand. It's just giving ourselves relaxation. You can feel your body relax when that happens. So this is I think it's a great topic. I think we should talk more about it. But I did want to remind everybody who's watching to go to Crushing Doubt on YouTube and click subscribe and click the bell for notifications. And we also are now up on Apple Podcasts. So if you prefer to listen, which I'm getting a lot of feedback, that some people like to just listen. I know that's true. My New York friends will probably be that way because they'll want to be on the train and they're gonna listen. So, thank you.
And visit
us
on social media too.
Oh, please do. Now, up next, we have our interview for today. It is Dr. Howard Schubiner. He is a big-time doctor in the TMS mind-body community. And the thing I love Howard for multiple reasons, but one of the main reasons I've interacted with, or the way that I've interacted with him, is through his research. He has just the most amazing research, and I'm excited to hear about his story, how he developed that. So I want to welcome to the show Dr. Howard Schubiner. He is the director of the Mind-Body program at Ascension Providence Hospital, just outside of Detroit, Michigan. He is a Midwesterner like myself. He is a clinical professor at Michigan State, but he's also a real giant of the field of mind-body medicine. And I'm really honored to have you with us, Howard.
Well, that's kind of you to say that. Appreciate it. I'm glad to be here.
It's not really kind. I mean, yes, I mean to be kind, but it really is true, because I've done a lot of research into things. When I was recovering, I read Sarno, but then I realized I needed a lot of other sources to really broaden my sense of what this field is all about. And of course, the field has evolved. And one of the places it's really evolved, I've found, is we're much better about research. Mm-hmm. So one of the reasons I wanted to have you on the show is that I have personally found your research, the not just the work you've done yourself, but also the kind of database that you have created to be extremely helpful, not only for me, but also for the people that I work with. Whenever I need them to, when somebody says, well, where's the research? I say, go to Howard Schubiner. And you're great for that. And it's been so helpful to me and so many people. So I'm sure there's a lot of people who are thankful for that. When I do these, go ahead, Howard.
Yeah, it's important that, if we don't have the research, either the data to back up what we're saying, or the new research to prove that our methods are efficacious, then why would anyone, listen to us or believe us? So
yeah, and we kind of have an extra burden of proof on us, I think, because there's some skepticism about this work, even though when you look at the science, it should be totally the opposite.
Right. Yeah, a lot of people in our circle think we already have all the research we need, and I don't feel that way. I think we still need more primary research that we're trying to do, as well as gathering the data that's already out there. Gathering to a large degree, but also if you look at the PPDA, the Psychophysiologic Disorders Association website, Dave Clark has done a great job at putting together a very nice annotated bibliography. That's really helpful.
I rely on that too. That's kind of in my resources for people, including on our website. I'm going to have that up there that people can access, because people have so many questions about this. So one of the things I wanted to know, I just like to know this about any practitioner in the field, is how you got into the work. I wondered if did you have a personal experience with mind-body suffering, or was it just more you found your way to it from interest? And
when I look back at my life, I've had several personal experiences with mind-body symptoms, but that's not the reason that I have gotten into this field as a practice of medicine. I got into the field in 2003 simply by reading one of Dr. Sarno's books that a friend of mine recommended. I read the book and I said, oh yeah, sounds really important. And I called Dr. Sarno and I asked if I could hang out with him, work with him a bit and learn from him. And he was more than happy to oblige me. And so I did that, and for just a few days really. But when I came back, I came to my boss at our hospital and I said, I want to start a clinic in seeing people with chronic pain and seeing people with potentially mind-body conditions, and see where that goes. And he said, fine, go ahead. So I did. I started talking to people extensively, in depth, just taking hours to talk to people about their lives and about their symptoms. And every patient that I talked to, I learned from. So that was 17 years ago, and I'm still talking to patients in detail about their lives and their symptoms, and I'm still learning every day. I started reading voraciously about the field and about neuroscience, and I'm still learning every day on that as well. And just gradually, me, along with many other colleagues and friends, put together, gathered the data, gathered the science, and began putting together what we hoped would be an extension of Dr. Sarno's work to make it as scientific as possible, make it understandable as possible, and begin to hopefully make it more widespread and more accepted within mainstream medicine, which was his wish for sure.
Mm-hmm. So I'm interested. What were you doing in the medical field before you came upon this?
Oh, lots of things.
Your pathway.
Lots of things. I had spent 18 years at Wayne State University as a faculty member, teaching and doing research there. I worked in a variety of fields there. I ran programs. I did research in adolescent medicine, in attention deficit disorder, some substance use work. I got interested in mindfulness meditation back in 1999 and have been teaching that since then. So a whole variety of different areas.
Did you find it hard to make the transition? I mean, I'm always interested in finding out for people who kind of switched midstream. And so I'm not saying you did that, by the way, but Some people feel like they did. They read these things and they were like, whoa, I have to practice completely differently. Did it feel that way to you, or more seamless in some way?
Well, it was a big switch. I mean, when I took on this work, it was different than anything I'd done before in many ways. I mean, I talked to people, I'd done counseling, a variety of similarities, but mainly it was a new area. But I didn't find it was difficult to switch into.
And when you read Sarno, something obviously captured your imagination or your interest. What was it? What really jumped out at you?
That's a good question. It's 17 years ago. I had an interest in mind-body medicine actually going back to my college years in the 70s. So I think it triggered old interests that had been there for a long time that I hadn't picked up on for many years. That was one thing. Secondly, it really appealed to me because it was challenging a lot of common views and norms within the field of medicine, and what he was saying seemed really correct and important. And basically, I'm a child of the 60s, and I like the idea of challenging norms and something isn't right, seeing if we can make it better. So it appealed to me, I think, on several levels.
And then you went to see Dr. Sarno for, you said, just a couple of days. You went to New York and just talked with him for a while, or what was that like?
Just talked with him and met with him and watched him see patients. And he was just very clear and definite about what he was doing. He had developed really clear ways of examining people, talking to people, educating people, and I found that refreshing and powerful. And so I decided to start doing it myself. And over time, obviously, as every practitioner does, they do things their way. So I began to put my little spin on what he was doing, and over time, that's evolved.
Speaking of that, you probably aren't all that aware of what my particular spin is, but and I have, I try to have a well-rounded approach. So I think a ton of what Sarno said was right. I love a lot of what you say, but I do incorporate things and think about things in my own way. And this podcast is called Crushing Doubt because I was thinking about this as you were talking about Sarno and how definitive he can be. I find that definitiveness is very important. And obviously we can't just be definitive about things that we want to believe. The reason you appeal to me so much is that you rely on the science. And that to me is how we can be definitive. But I find that it's really important for the people I work with to feel that they can be definitive about their own experience, how to think about it, maybe even what to do about it. Has that factored into your thinking at all? I'm curious about that.
Very much so. I believe what you just said, I believe wholeheartedly. And I practice that every day. And I've been devoting a lot of my teaching in recent years to helping clinicians be definite when they can be certain. When they're certain that this is a mind-body condition, they can be definite, and they can explain that in definitive and no uncertain terms. And there's lots of clues to when a particular symptom is clearly non-structural. It's clearly a mind-body problem. And I've been cataloging those and writing about those and teaching about those. And, right now I'm involved with creating a training app for physicians and other healthcare professionals on how to diagnose these conditions. So I think that's critical.
That's fantastic to be working in that direction. I was thinking when I'm doing this podcast, one of the things that I am thinking about is, I did this podcast because I really do want to change the dialogue. I want to contribute to getting this message out there, but I want to do it in the right way. So I was curious what you would say about what should we be trying to convey to people who are watching this and listening.
Well, I think the one of the most important things that we don't understand or haven't really paid enough attention to in modern medicine is that it is extremely common for people, healthy people, normal people, not psychotic people, just people, human beings, to have symptoms, to have the manifestation of symptoms, a wide variety of symptoms, due to non-structural causes. In other words, due to neural circuits that have been learned and reinforced and manifest by their brains. And it's shocking to say that most people with chronic pain do not have a structural problem in their body to account for or explain that pain. To me, that's a revolutionary statement. And I think it's completely true. Because when you look at people with chronic headaches, migraine or tension headaches, or a variety of other types, there's no structural problem in the brain. And all neurologists understand that. When you make a diagnosis of fibromyalgia, or irritable bowel syndrome, or interstitial cystitis, or pelvic pain syndromes, the vast majority of those people do not have a structural problem to account for their pain. And everyone can understand that if they're willing to look at that, instead of hiding behind a name like, oh, fibromyalgia, as if that means something, or pudendal neuralgia, as if that means something. It doesn't mean anything. It's just describing that someone has pain. And of course, when you look at chronic neck and back pain, if you look carefully enough at the data that we've uncovered, discovered, put together from other people, and the data that we've created in our own research, the vast majority of people with chronic neck and back pain do not have a structural cause for their pain. And that is so counterintuitive and so contradictory to what most people are hearing from their physicians or physical therapists or chiropractors or other healthcare providers when they seek care.
What do you think about, this is something that I often say to people, what do you think about when we talk about kind of everyday mind-body experience? Because I'm writing a book, which is taking forever because every time I start to write, I'm like, oh, now I understand something new. And it goes and goes and goes. I'm sure you're familiar with this. But I talk to people about the fact that crying, I suddenly realized crying is what's called psychosomatic. It is an emotional experience that becomes real in the body. Between that and blushing and goosebumps, or even sexual arousal is all about blood flow, tension headaches. We know so much about this, and I'm always curious about why don't people see how far this goes?
Well, there's a separation they make between what they would call like, oh, these are just normal minor things that don't really amount to anything. How can pain that's so severe and going on for 6 months or 6 years or 16 years be solely due to the same processes that cause someone to cry or to blush? It just seems like a much greater scale. But it turns out
cry
that,
for 16 years.
Right, exactly. Hopefully not. But it's true that it can be, and most of the time is, due to the exact same processes. But it's just that these processes can become ingrained, can become habitual, can become positively reinforced as a vicious cycle, as a neural loop that goes on and on. And the fact is that most people with chronic pain get worse over time because of that vicious loop of pain leading to fear and worry and focus on the pain, frustration with the pain, trying to fix the pain. All those things actually reinforce the brain to feel more endangered. And then your brain creates more of this alarm, this danger signal that's manifest in pain. The other thing that happens over time is that most people with chronic pain, their symptoms spread over time. So the pain often will spread to more and more areas in their body. Again, just because of this vicious cycle. It's not because they're getting more and more damaged physically. And new symptoms will tend to arise. So they may start with neck pain, and the pain spreads all the way down their back. So that's spreading pain. But then they may start to get a burning pain, or they may start to get anxiety, or they may start to develop insomnia. And everyone say, well, of course you're having anxiety and insomnia because of the pain, and that certainly is a contributor. But what we're seeing is that it's the brain upping the ante and increasing the alarm signal. And it's kind of like if you're talking to somebody and they can't hear you, you talk louder. And that's exactly what the brain is doing in trying to get your attention, so to speak, because the brain feels endangered in some way, shape, or form.
That was making me think about a particular way that I think about it, which is that Sarno talks about that these symptoms are meant to be a distraction from the emotions, and I don't dispute that, at least in their onset. But I have found that these symptoms are also trying to communicate something between the self and the self. And I don't know if that's what you're saying, but it does sound along those lines, because when I think about, well, why is the brain upping the ante? To me, it's trying to convey the message. You are feeling in danger. You're not feeling okay. Is that in line with how you think about it?
Yeah, I think about it exactly that way. And I would say that there's two sources of where that danger may be coming from. One source may be an emotional danger. There may be something ongoing in someone's life, that they have a situation with a child, a spouse, a boss, or whatever, that's ongoing and creating a sense of danger. Other times, the emotional situation may be that the brain is trying to communicate to you that you're trying too hard, or you're too hard on yourself, or you put too much pressure on yourself, or you put yourself last, you never stand up for yourself, those kinds of things. So those are categories of emotional danger. But there's another category of danger that the brain may be trying to communicate about, which is simply on the more kind of physical side, that you're having pain and you're worried about this pain and you focus on the pain, and that makes it worse. So that's part of a vicious cycle that's not really an emotional issue. Because if the onset of the pain might have been because of a physical injury, but then that physical injury, the neural circuits for that physical injury can become learned and habitual. And this may occur in the absence of any major emotional upset or any major emotional trauma. And as you pointed out, it may be also that an emotional issue triggered the symptom in the first place, but now the symptom is being reinforced and persists, not because of the emotional issue, because that was 3 or 5 or 8 years ago. And now it's persisting primarily because of this vicious cycle. And so that's why in our treatment, we work on 4 major components, but 2 of them are dealing with the pain, fear, pain cycle, and dealing with the emotional issues, if that's necessary.
It's such a great point, and it's very in line with how I think about it, because what I came to see in my own recovery was that it isn't all emotional. A lot of it is about your thought processes. It's about fear. It's about doubt. It's about confusion, questions you have. And that, I think, is really important for any of our audience, whether it's me or you or Alan Gordon or whoever's talking about this, that I get a lot of questions about, but I don't see how it would be emotional. I'm fine emotionally. That can be true. I'm 100% in agreement with you, and that's what I've seen, that it can be all about your thought process. And you, I think, are really good at articulating then, well, what is happening in that fight or flight sympathetic nervous system response. I had a question about it. I think I know some of the answer because I've read you and I'm on an email listserv with you, so I know some of how you think about these things. But one of the things I'm most curious about with neural pathways is how deeply ingrained do you think those are? How hard are they to change? And part of the reason that I ask is that I see when you hit on the right way of understanding, the fear just goes whew, and it seems to me it can change very quickly. But I'm curious what you have found either in your research or in your thinking about neural pathways and that quick change.
Yes, of course it can change very quickly, and that's one of the first things that you learn when you look closely and talk with people who have pain, that the pain sometimes will turn on and off. Well, it doesn't mean that it's gone, forever or even gone for an extended period of time, but the fact that it can turn on and off within seconds or minutes is a demonstration of the pain being dynamic as opposed to static. Now, some people have pain that's continuous and seems like it's there all the time, but even in those people, most of the people that you talk to, their pain will vary at times during the day, and it will vary based on certain activities or certain triggers. So if you pay attention to those, you're seeing the manifestation of neural pathways or neural circuits in the brain as being dynamic, as being ramping up and ramping down, turning on and turning off. So of course, it change because it's frankly almost always changing to some degree or another in the vast majority of people.
Do you think an activated neural system, though, does it make people more vulnerable to going to those places because you have had that? Or do you feel like it really doesn't matter whether it's happened before? It's more about current thinking and experience.
Well, it depends on the person. It certainly can be both. We know from research studies that people with adverse childhood events have a hyper-aroused or overly sensitized danger alarm mechanism in the brain. There's a lot of research on that. Those people are more likely to have current stressors trigger pain or other symptoms due to neural circuitry in the brain. But obviously, it should be obvious, but this is a human condition. Everybody can have mind-body symptoms, and everybody does at some point in their lives, at least to some degree. And so people who don't have adverse childhood experiences, of course, everybody has some, but people who don't have adverse childhood experiences are certainly able to and can have mind-body conditions. Some people may have very little trauma or stress in their life in a sense, but maybe they're kind of sensitive people. There's a lot written about, quote, HSP, highly sensitive people. So people who are highly sensitive, again, it's more likely that they will develop symptoms when they run into situations in their life that appear to be dangerous to them.
And I when I work with people like that, and I guess I would consider myself one of them, even when I work with myself on it, one thing that I remind myself is this comes from a strength. This is a way that we are attuned to our environment. It's a way that we can be empathic to other people or even ourselves, or we can be very aware. So there are great strengths to it, but there's a saying in my family that, people have the defects of their virtues. And this is certainly one of those cases, because I can feel like I'm riding all these different waves with the amount of sensitivity. But interestingly, it's allowed me to get a lot of insight into things, and the childhood experience is so important. You worked in pediatrics for a long time, if I understood correctly. Is that right?
I have trained in pediatrics as well as adolescent medicine as well as internal medicine, correct.
Mm-hmm. Well, when I saw that, it made me wonder, okay, I wondered how you thought about the ACE study, the Adverse Childhood Experiences study. And for those who are listening and not familiar with it, adverse childhood experiences we're not just talking about like, you had a falling out with a friend or something. We're talking about that there was some kind of abuse or neglect or an alcoholic parent or the loss of a parent. At least this is my way of understanding the ACE study. I don't know if that's what you mean when you talk about adverse childhood experiences, but most people have had some form of it. I mean, divorce is an adverse childhood experience, I think, or even the lack of a divorce with all the fighting that can happen. But
correct.
I was curious, when did you come across that study?
What was that question again?
When did you come across that study, and what was your response to it?
Yeah, those studies are extremely important. They were done quite a while ago now, and they were kind of overlooked or, not really noticed for many years. But it's just becoming more and more obvious how important they are. And as you point out, reactions that people have to difficulties in their life often are adaptive at that point when they're children or younger people, but those same reactions may not be adaptive later in life. Hiding, avoiding, curling in on oneself, numbing emotions, those are things that were necessary at that point due to the situation, but can be, like you say, kind of not as helpful later in life when we have to learn new ways of coping and we're not in danger. We're not actually threatened. It just feels like we are many times.
I wanted to add into the list of those experiences the goodest element that Sarno talks about. That was very important for me in my recovery, because when I was reading the book, I had never felt so well described. Mm-hmm. And I just thought, I'm, a nice guy. I look out for people. When I read that, I was like, whoa, there is a me type, and I did not realize it. And one way that I have come to think about it is that it is an adaptation to childhood experience, and it worked well for those children, generally speaking. Or at the very least, it worked very well for their families and the people around them. But then eventually they find it's not working so well for me, at least not as an adult, and that's when a lot of the symptoms come in. I'm sure I know you're well versed in that, but do you see that as a pretty central part of things?
Well, the personality traits that we talked about that included this feeling guilt, not putting oneself first, being overly perfectionistic, overly goodist, all those kind of things, often those really ring home to people, and they can really see how they may play a role in the development of the situation in their life and in their brain, which can manifest as mind-body conditions. So that can be extremely helpful. On the other hand, everybody has some of those. I mean, what do people want to do? I mean, the other day, somebody sent me a super sweet email, like, thank you so much, you made a big difference in my life. I really appreciate, blah, 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 all the sweet stuff. And it was kind of overwhelming. I didn't know how to respond, but my first thought was, I'm just trying to make my parents proud of me. And that was my thought. And but everyone has that. This is a common, this is how we are, we want to make our parents proud of us by and large. There's some people who don't really care, but if you look at the vast majority of people, a lot of people are going to have these same kinds of, quote, personality traits. So I don't think they really differentiate people who, are more likely or frankly less likely to get mind-body conditions, but they're certainly super common in the population we treat.
It's a good point. I think there is a lot of overlap, but to me, you made the key point, which is that it's more that it's such a useful tool at helping people to see how they're living their lives and how it's playing out. And that's how it worked for me. It's not like I decided, well, now I'm going to stop doing these good things. Or, of course, everybody is striving to feel good about themselves and to make their parents proud or make somebody else proud, or I think sometimes people run into trouble when they feel like they can't make their parents proud, and then they're really stuck in that loop with themselves. But if they can make themselves proud, that works maybe even better.
Well, a big part about this work is really what I would call narrative medicine. It's it's helping people create a story for themselves. If they come in with the story is that bad things happened to me, so I was unlucky. On top of that, I had all these different symptoms, so I'm unlucky again. And I went to the doctors to fix me, and they couldn't fix me, and now I'm broken and I'm stuck. That's a story. But there's another narrative that could be explained here, or could be taken on. I'm the way I am because of certain experiences that happened in my life. They happened for a reason, in a sense, and I'm learning from them. And now I see why I have these symptoms. And the reason the doctors couldn't help is because they didn't understand the problem. And the solution to the problem is me, and how I can change who I am, how I see myself, my agency in the world. And that's a completely different narrative. And that's a narrative of healing and recovery and empowerment. So, to a large degree what we're doing. And when people get those aha moments where they can begin to see that, and whether they see it through the science, through the understanding that MRIs aren't indicative of the cause of back pain, through the personality traits, through the understanding ACEs, through the understanding that their symptoms are turning on and turning off, or shifting or moving or spreading. When they can see all that, all those aha moments add up to a big aha moment. It's like, wow, now I understand what's going on, and I can get better.
Well, and I think that's really what people are craving, is understanding. Because when I had 8 years of back pain, and first of all, I was baffled that no one in my circle knew about Sarno at the time. I think it's more common now, thankfully. But I really wanted to understand. Even if I just had an issue that I was stuck with, I needed to understand it. It wasn't making any sense, and that's where getting rid of doubt, being certain, is really important. And you have those patients who will come to see you. I've heard this story many times, and people will say, "I'm 99% sure it's TMS." We know that they're going to hear there's 1% I don't know, and that's going to leave them circling. And I'm not saying be certain about things you can't be certain about, but let's also not be so careful that we don't say things like, "I'm certain that the sun goes down at night." That's true. There is some objective truth, and I think the understanding to me is a lot of times the window in. Sarno said at the time that he was grappling with this that about 15 to 20% of people could accept this diagnosis. My feeling is I think 100% of people can accept this diagnosis if we give them the right information. Now, maybe I'm too idealistic.
That's optimistic.
I'm a very optimistic person. But I guess what I'm saying isn't necessarily that I think we'll have a 100% success rate. It's more that I feel that everybody has the opportunity, because the only window we really need to get in is through understanding and truth and science and logic, all of the things that really apply. And so I was curious, I wanted to ask you one last question here. What do you think are the main roadblocks to people being able to understand this or utilize this?
Well, certainly one of the main roadblocks just has to do with the diagnosis. It has to do with the common understanding that if something hurts, there must be something structural wrong. And then on top of it, they've been to doctors, and doctors have given them diagnoses, many times differing diagnoses. I had a lady I saw this week, a young woman who had pain in one tooth, and she got a root canal, and that didn't work. And then she got an extraction of that tooth, and that didn't work. And then the pain jumped to the other side of her mouth to a different tooth. So they did a root canal in that tooth, and then they extracted that tooth, and that didn't help. And then she started getting more. She ended up with 6 teeth being removed. Yeah. All for, none of them were damaged. None of those teeth were actually damaged. I mean, this is really traumatic to somebody. And I saw a guy a while ago who had, I think, 11 different pelvic injections, over the course of several years. And he's getting worse and worse because he's getting more and more traumatized by medicine. So when medicine can just make things worse when we misdiagnose people and we traumatize people. So that's obviously one of the first and major roadblocks to understanding, what's going on, because it's not common in our society and our cultural understanding and our medical understanding at this point in time.
Yeah, and that's why I think our working to make this understandable, to make it scientific, to make it logical, and I encourage people to have skepticism and doubt, because they're going to anyway. So I think we should engage we should meet them where they are and work to try to understand them. But Howard, I wanted to thank you for coming on and for your work, because I get the sense that you're not one to bask in the glow of people's appreciation for your work, but you really have helped so many people, and I'm hoping to carry on that tradition and continue to grow this field. And thank you for joining me. I really appreciate it.
Well, I think you're making your parents proud.
Oh, thank you, Howard. That means a lot.
Can I just say I have such respect for Howard and the work that he has done. The amount of research and the importance of that research out there, it's unparalleled to me.
Isn't it great when other people do it? 'Cause, like, research is just not my thing.
It's not mine either, but I really understand how important that measurability is, and
no, that's why it's great. Because they do these things that need to be done, but it's just not my thing. I mean, I went and got a PsyD, a clinical psychology degree, because I did not want to do the research. It just wasn't of interest to me. I knew I wanted to do the clinical.
And I'm so grateful to the people that do all of that work, because it takes so much time, and it takes such a commitment and a passion. And I feel that that's what he has for this work. And so many people are benefiting from it. So thank you, Howard.
Yeah. And you know what? This is a good segue into returning to our discussion about the columns that I use in my short-term consultations and that I talk about in my seminars. Last time we talked about the emotions column and how to use that, and how I develop it with the person that I'm consulting with or in the seminar. So the reason it's a good segue is, at some point, it would be amazing if someone could actually help me do the research of, well, what are the actual outcomes? I mean, I see this all the time. I'm helping people. I see them get better. They tell me they get better, but it's an N of 1. And research is very important. And I've got all kinds of ideas for studies for other people to do.
But here's the other thing, though. Don't you also? I get stuck between the research and just, when you meet someone that actually has had an incredible experience, that, I go back and forth and like, okay, well, the research says, if I do these exercises, that's, going to help whatever ailment I might have. But if I have a friend that went through the exact same thing and had an incredible experience, say in this program, that I'm much more likely to go that route. And
well, this is one of the reasons why we offer so many varied things on this podcast and also on our website, because we have those testimonial interviews, because I'm there with them. But, hearing, or when Vitaly was on, or Eddie, these are people who have been through it. Or even when I talk about it myself, it can really, people have different access points. So that also, it's a good second segue into what I was going to talk about in relation to doubt. So usually in the second session of the consultation, and usually in the second or third seminar period, I talk about the column of doubt. And one of the reasons that I think it's so important is that in the mind-body community, there's a lot of things that we all have overlap about it, and then there's things that we really do differently. Howard has a workbook in his book that many people have found to be extremely useful. He developed that. I don't know if he did research for it, but knowing Howard, he probably did. And if he didn't, there's no shame in that, because he was doing all the research for all the rest of us anyway. But one of the things that I developed, and I got this from my own recovery, is that you can't necessarily just focus on the emotions and what symptoms they're causing. That's the first column. It's really good to develop the basic themes that lead to your symptoms. It's good to think about the timing. We talked about this last time. But when it comes to doubt, it's about a whole different ball of wax. It is usually about, or the entry point is, we start talking about the symptoms that won't go away, that are just lagging. You can't get movement on them. And this is a lot of times people come to see me because they've been working on the emotions and they're not getting there. And that's because the answer is not always in the emotions. In fact...
go ahead.
No, you.
So let's just say I'm coming to see you.
Yep.
And we're talking about this. What happens? Like, what happens in that discussion? Like, what are the types of things that you might ask me to get the information that we need?
Okay, so what I'm looking to do when it comes to the doubt column is get the doubts articulated. And for some people, like me, I had all my questions lined up, the Eric Sherman session. And I knew what I wanted to ask, but that's not typical. That really isn't.
Are people kind of like, do they look at you like, I don't,
yes,
I don't know?
It's varied. It's varied. Some people will jump right in and say, well, my main doubt is this TMS? How could this symptom be TMS? Some people will say, I have too many doubts to tell you. I don't even know how to begin talking about them. Mm-hmm. Other people will say, can you tell me what you're talking about? It's just like what you said. Mm-hmm. So I do it differently based on, those different people. Some people want me to dive right in on a specific doubt. They'll say, well, okay, so tell me, can this symptom be a mind-body thing? And sometimes I'll say yes, absolutely. But usually I will elaborate. I'm more helpful than that.
Do you ever say no? Like, would you, I know you've kind of talked about this in the past, but it seems to me that like everything, could potentially be a mind-body, connection.
There are absolutely things that are not mind-body experiences. I have people come to me and say, can a hernia be a mind-body issue? Nope. It can't be. Mind-body issues.
But maybe the lingering effects of that after
pain from a hernia can be a mind-body thing, actually.
Yeah, I'm thinking like it continue because of a trauma that might
yes,
be...
there can be overlap, but I like to make the distinction between... So here's a rule of thumb that I always say is if the body is capable of doing it, then TMS can use it, essentially.
That's good.
And so the body is capable of getting a hernia, but it's not capable of making its own hernia.
That's, very good point.
So that's why... it's the same thing with a broken bone.
Right.
Your body can't just be like, I'm going to break your arm. No,
right.
Thankfully, that does not happen. So there are these outside of us physical events, or I guess in the case of a hernia, it's not entirely outside of us, but it is because of actual physical pressure.
Now, what about something with, the digestive system? I know I'm getting a little bit off track, but, if you're having, IBS or any of these symptoms that are actually happening within the body, that they don't feel like they're doing anything to make that happen, but it's happening.
Yeah. Oh no, there are digestive processes and pain in the gut, all kinds of things like that. That can happen. Constipation, diarrhea, pain.
That's when I would probably
gut,
take what you said about timing to really focus on when those things are happening. Every time you travel, you might have this experience, but never kind of connected the two, right? Isn't that kind of
exactly
what you've said before? Yeah.
Yeah. So that fits more with the emotions column. That's because that is an acute symptom. Just as a review, the emotions column is especially useful for acute symptoms, the onset of symptoms, even if they've lasted a long time, or the uptick in symptoms. These are just rules of thumb.
So with doubt, what are the details then for that column?
So doubt is usually related to something that has been not moving a lot. You have it all the time or most of the time. And one way that I start people out, again, it is varied. I just want to say that. This is not always going to be one way because I do have to adjust to how that particular person is presenting. But one general rule of thumb is I talk about 3 levels of doubt. There is doubt as to whether this is a mind-body issue, and that all kinds of questions, like what you were talking about before. Is this, can IBS be that? Can a hernia be that? The second level is, okay, I believe this is a mind-body issue, but how curable are mind-body issues? Now, the word curable is a little bit tricky because it's not really a cure that we usually get. It's more you get to know how to control these things or interact with these things in helpful ways that bring you new information, that help you feel more at ease about it and help you alter the symptoms. So it's not exactly a cure, but I mean, there are times, I suppose I cured my back pain because I mostly don't have back pain. It will happen every once in a while, and that's in relation to an emotion. So that's the second level. The third level is, okay, yes, I believe it is a mind-body issue. I believe that mind-body issues can be cured, but I'm not sure it's going to work for me. And that can have different forms. It can be, it's not going to work for me because my symptom is particularly bad, or my symptom's been here for a particularly long time. But it's all idiosyncratic. Or it could be, it's not going to work for me because I worry all the time. Something about the self.
I can relate to that in the past.
Well, don't worry, we'll get to that. If you need my help, Julie, you know where to reach me. So,
but worry is a big one, right? But I wouldn't think right away that is doubt. That's an expression of doubt, right? Is that what you're saying? That would be
that
kind
is
of
what I'm saying.
Yeah, I that's interesting.
Fear is the emotional version of doubt. I mean, I never thought about it that way before, but when I started thinking about what is doubt, confusion is the intellectual form of doubt. Fear is the emotional form of doubt. But you also just might have questions.
I was going to say curiosity. Would curiosity be also on that?
Yeah. Here's a good example. When I went to see Eric and invented, the doubt column myself, because I knew I needed these questions answered, I said to him, can TMS be caused by a bad relationship with someone else? And he said, nope. No. You could have the worst relationship in the world, but it's all about your relationship with you. Now, I didn't just take his word for that and say, okay, fine. And I don't expect people to do that with me either. If I'm going to effectively resolve doubt, it's all about the person's mind I'm working with. So I can say things definitively. I can say a rule of thumb like what Eric said there, but ultimately it's the person's mind that I'm working with. So I am assessing, how is this mind doubting? They might be thinking, oh, I had a car accident 10 years ago and I think that's what's causing this back pain. Or they might think, well, I was lifting weights and it, caused this neck injury. And so we start to explore this. We start to bring out the questions. And a lot of times they don't realize what questions they had. They're just like, oh, I just had this neck pain. I don't know. And I say, okay, well, what was it from? And they're like, oh, well, I think it was from this, but I never really thought about it. It just wasn't going away. So I'm like, okay, but wait, you have a specific doubt there. Your doubt is, in fact, there's two doubts in there. One is, did this, I'm making this up, of course, but did this lifting weights cause an injury? And then there's also, do injuries last that long? How long do they last? Usually there's just hundreds of doubts that I can really start to articulate. And I guess it's because of my own doubting nature or all the questions that I've had that I can help people to develop this. So when you come in, let's say you come in to see me, I would say, okay, so I give you the 3 different levels. I'm like, where is the doubt? Now, some people would say, I don't even know where to begin. And then I'm like, okay, well, let me just, and I start hunting around, because all I'm trying to do is figure out, how is this person's mind working? How are they thinking
So I
about
imagine
this?
too that there's probably people that are like, I don't doubt anything. I just have this pain. Like, yep. I'm not a touchy-feely kind of person with myself. I don't have that kind of relationship. It's just, I just want to get this resolved.
Absolutely. And then that also depends, because there's lots of people who say they have no doubt, and then you start exploring it, and they're like, oh, I don't have any doubt, but I'm just not sure if it's a mind-body thing. And I'm like, well, that is doubt right there.
Yeah.
So
you can probably break that down pretty quickly, I would assume.
You usually can. Now, there are people who don't have a very active doubt column. Now, this is interesting, I think. The emotions column, when we develop those themes, those don't tend to go anywhere. Those are your themes. And the mind-body map that I do, you have those themes involved. When it comes to the doubt column, we slowly shrink it until it's down to very little. The whole idea is really twofold. One, You have to understand how mind-body issues work in general and for yourself, those two things. And you have to articulate all of your questions, fears, confusions, all of it, and get it as answered in as best form as would work for you. Now, that's going to be different for different people. So one of the things I've tried to develop, and I happen to be particularly good at this, is getting to those questions very quickly. I do the same thing with the emotions column, as we talked about last time. I'll help people say, okay, well, you are thinking this theme, but actually, if we get more specific, it's this. And so we're getting people a lot of information. So we want to get full information so it's understood, and then we want to have people ask their questions and get their questions answered. So essentially, I'm structuring like a personal course, or if I'm doing a seminar, I might be helping people think about it in a kind of more general way or answering questions about it. And then they start to get to a place where they feel like they can understand their mind-body experience, because it always makes sense. Is that happening
in the doubt, like when they're working with emotions, with doubt, with each of these? Is this something that happens on their own time or in session with you or in a group, setting? Would they be sitting there, or is it kind of a spread out amount of time that they're thinking about these things? I'm just curious.
The answer is always depends, but that's not a satisfactory answer. So I'll try to do better than that. So the way these consultations are set up, because I want to get people as much information as possible. I want to make it cost effective for them. And to do that, you really got to pack a lot in, and I'm capable of doing that. But the first session is about emotions, and then there's a week in between usually.
Okay.
Because I give them space to kind of think that through and be able to metabolize them more. Then we move on to doubt. And then we do the doubt session. Now, I have this happen frequently. I was working with somebody just recently, and we did the emotions column in one session, but we started in on the doubt one, and we started running late because we went back to the emotions one for a little bit, and we'll jump around on this map. It's basically this mind-body map is just you and your symptoms on paper, notes on it, and we start to hone it. And so with this person, we went into doubt, so far that when we got to the third session, we were still on doubt. And then we decided, you know what? Let's do an extra session. That's okay. Some people can't afford to do that or don't want to do that, and I tailor it to them. But in this case, this was somebody who was willing to do that and felt that it was really good to do the thorough job of getting it understood. So there's work that happens in between sessions. Now, I will say this too. I also encourage people, contact me if a doubt comes up. If they're like, oh, I'm worried that I had this injury, and they'll text me and say, is this a mind-body thing? Or, do I need to worry about this? Do I need to go to a doctor? And of course, if I'm not sure, I do send them to a doctor. But so it's really pretty varied, I would say. But if you think about it this way, this clarifies the whole thing. And then we're going to get to some questions. If you think about it from the vantage point that the doubt, really the whole consultation or the seminar is designed to help you understand mind-body experience. That brings all the fear down, all the sympathetic nervous system response down. It gets us into a position where you feel like if you understand what's happening, then you understand how it can stop. And that gives people a lot of hope.
Absolutely.
All right, so let's transition.
Intriguing. I'm ready to dive in.
Try it.
I know.
We'll have to try it. And of course, we'll talk more about this, and we're going to find out who wants more information on specific things. Maybe people are going to want to know even more about those sessions, and we'll find out. So I got a question, and I'm gonna read it and then try to answer it, because that's what I like to do with questions. So this is from Matt. He says, MIT recently reported, and I'm just reading this. I did read this before, but I'm not remembering which it was, which is interesting because it turns out it's about brain fog. Very interesting. So MIT recently reported that several people have had cognitive dysfunction after getting COVID. So this is also a time-sensitive thing. Others have reported similar concerns with Lyme Do you feel that chronic infections are simply a manifestation of TMS or mind-body issues, and it's not the infection that has been cured, it's merely the limbic system not being fully rewired from the stress of the situation? Wow. Fantastic question, and this does highlight an aspect of something where, first of all, I take my cues on medical things from medical doctors. And these are medical things. COVID is a medical condition, of course. Nobody's really arguing that. But are the effects a mind-body thing? Well, it could be, but I'm not going to say anything about it until they've seen medical doctors, especially with COVID. It's a thing that we don't really even know how it affects people a lot of the time. So that's in a different category than Lyme disease. Lyme disease is also very interesting. I have talked to medical doctors who have very varied opinions about this. I talked to somebody who was actually my best friend from elementary school. Hello, Chris. And he works in New Haven as a doctor, and he said that Lyme disease essentially, usually, is more of a mind-body kind of thing. He didn't know how to treat it, but I was surprised to hear that, whereas some other doctors are like, take antibiotics right away. So I don't have a great answer for whether somebody has Lyme disease or not, but I do feel comfortable once they've seen doctors weighing in and saying, okay, well, if they've cleared you, you're okay from life and death things or things that can affect you. I will say this, though. Mind-body conditions can definitely cause brain fog. I have a friend, actually, her mother was diagnosed with Alzheimer's. She was having brain fog. To me, from a mind-body perspective, it was very clear what that was. But, everybody's got to come to it in their own time. And I was she's very interested in this kind of stuff. So, hello, Rachel. I'm just throwing out lots of names today. But she was able to see that connection very, very quickly. I had helped her with plantar fasciitis, and then, every once in a while we check in about when she has an issue. So, the answer, I would say, is yes, people can have cognitive dysfunction from mind-body issues, but if there's any serious medical condition potentially involved, I want to get that checked out first. One other question we're going to talk about that people ask me a lot, and I want to do it on this particular segment because we were talking about the doubt column, is people ask me, how do you know when something's doubt or when it's emotion? I don't know if that's a question that would have occurred to you, Julie, but probably it would have at some point. You're an inquisitive person. So basically, I use my rule of thumb first. These are not hard and fast rules. I kind of think of myself as like a symptoms detective. So if we're talking about the onset of something, I start with emotions. If we're talking about an uptick in something, I start with emotions. But if we're talking about something that has basically been there for a month or longer, I usually start with doubt. Now, that doesn't mean that's where we're going to end up. You could end up realizing, you know what, you have a thing that's kind of immovably there, but really it's actually an emotional thing. Or you could, go ahead.
I was wondering, do you think that timing of treatment is vital because I'm just thinking with what you said, if you're wondering this and it is something that's been happening for a long time, but you also have multiple things happening in your life, is it imperative to take that time, even despite everything that you may have going on in your life, to get going on this? Or do you find that the timing needs to be when someone has space in their life to dig, to think, to deal with the things that come up?
Wow, there's so many good questions in there. I guess here's what I would say to it. I'll try to be brief about it, but the basic idea there is that, first of all, I want to help people understand this in a way that's such a short form way of understanding it that it's just happening naturally. As a result, it in the long run, it's not going to take you much time. It's going to be it's like a way of thinking about things. And then it's just always running. So ultimately, I don't want it to be the case that you wait on it. Right. I think there's good information in it. there's always good information, and it's your body's telling you a lot of things, so we don't want to miss those things. At the same time, if you're overwhelmed, yeah, you can wait. It's your time frame. It's your mind-body experience, and so you get to figure out when you want to do it. Now, this also brings up one other point that I'll wrap up on here, which is that you can have doubt and emotion active at the same time. It happens all the time. In fact, if you've got multiple emotions going on at once, of course you're going to have doubt. Well, which one is it?
Right.
Is it any of them?
It changes every 5 minutes.
And, next time we're going to talk about the power column. It's the column that I find requires the most explanation, because what does it mean? If you think doubt is a confusing concept, let's try on power. So we're going to look at that next time, and I'm really excited about that too. Thank you for watching. Please click subscribe, hit like, and ring the bell for notifications on YouTube. Sign up for our newsletter on crushingdoubt.org for information on new episodes, or to sign up for my live seminars.
For questions you would like answered, please email info@crushingdoubt.org. And if you'd like to support our podcast, head over to Venmo and search Crushing Doubt.
I'm here to help you resolve your doubts on your journey and find powerful, peaceful, and happy living. You can find us on all social media platforms at Crushing Doubt.